The robotic-assisted TLIF procedure begins with the patient positioned prone on the Allen Advance table. A crucial three-defined scan is performed by the robot. This scan meticulously maps the surgical field, identifying any potential anatomical hindrances or obstacles that could impede the robotic arm's movement during the procedure, ensuring a safe and efficient workflow. Following the three-defined scan, the robotic arm is moved to the snapshot position. This step is essential for establishing a precise reference point. The robot captures its exact position relative to a reference tracker, creating a baseline for navigation. A navigated blunt passive planar probe is then used to guide the robotic arm to the precise region of interest. The robotic arm then assumes a position to attach a fiducial array, also known as a star marker. This marker contains radiopaque beads, which are essential for intraoperative image registration. By overlapping these beads with the patient's anatomy in the intraoperative CT scan, the robot gains a precise understanding of the patient's anatomy relative to its own position. The star marker is carefully brought as close to the patient's bony anatomy as possible without touching the body. This is crucial to prevent any back pressure on the marker or its extender, which could compromise accuracy. Placing the star marker closer to the bone allows for greater coverage of vertebral segments, as it can be positioned within the isocenter of the O-arm, maximizing the number of vertebrae captured in the scan. After the star marker is securely in place, the patient is covered with sterile drapes. The O-arm is then brought into the operating room and positioned precisely over the region of interest. Once adequate coverage is confirmed, the O-arm scan is performed. The acquired images are then transferred to the robot system. The robot processes these images and attempts to identify the star marker or fiducial array. Upon successful identification, the robot displays a star marker found message, confirming accurate registration. The O-arm can then be safely removed from the surgical field. We will cover what happens if the star marker is not found in another video. With the star marker identified, the surgical planning process can begin. This starts with marking the region of interest by drawing a line along the spinal canal in both AP and lateral views. Next, the robot automatically segments the vertebrae. While the robot performs this initial segmentation, it's vital for the user to verify and number each vertebra, ensuring accuracy. More details on the planning process can be found in other videos on our channel. After labeling, the vertebral axes are approved. In the axial view, we aim to align a line bisecting the vertebra with a dot placed on the anterior canal. In the sagittal view, a dot is placed on the posterior vertebral body, and the line is aligned along the pedicles or upper end plate. This is repeated for all the vertebrae. We then move to the planning screen where we select the vertebrae to be instrumented. The axial and sagittal views open by default, along with the coronal view at the bottom. We can plan cages using the robotic planning software. In this case, we've chosen to show the cage planning first. This allows us to determine the optimal cage height and simulate the desired correction and disc height restoration before moving on to screw placement. To proceed, we add screws to the active vertebra and meticulously arrange them within the pedicles in all three views. We carefully check for potential breaches, the possibility of slipping along bony slopes, and the overall quality of the bone along the planned trajectory. Here, the planning process is shown for both levels in fast forward for helping you see how we do it. Once satisfied with the screw placement, we utilize the skin level feature. This feature allows us to visualize the planned skin incision positions. Critically, we can modify the screw trajectories to achieve desired incision sites. Often, we aim to minimize the number of incisions by directing multiple screws through a single incision. Here you can see an example how we are modifying far incisions to come together as single incision by redirecting screws, thereby preventing bigger or more number of small incisions. The software can simulate the resulting correction and the achieved disc height. This allows us to fine-tune the cage position and size to achieve the best possible correction. We can visualize the pre- and post-simulation views to assess the correction. With the planning complete, we proceed with the procedure. The robotic arm is sent to the predefined trajectory. A small incision is made using a robot-compatible knife, followed by the insertion of a trocar and sleeve through the robotic arm guide, reaching the bone. The position is confirmed using navigation. A high-speed drill is used to create a pilot hole. This is followed by tapping the drilled trajectory with an undersized navigated tap. The outer sleeve is then removed from the robotic arm guide, and a navigated screw is placed up to the desired depth. Alternatively, we can also place a guide wire and keep for placing a cannulated screw later. If we are planning a TLIF on one side only, screws are placed first on the contralateral side, and guide wires can be placed on the side where the TLIF will be performed. If a bilateral TLIF or decompression is planned, guide wires can be placed on both sides. In this case, we have inserted screws in both left L5 and S1 as we had to perform the decompression and cage on right side. We have also put navigated right L5 screw as it won't come in way of the retractors. The right S1 screw trajectory is kept drilled and tapped to put the screw later, either under vision or robot-guided, which is up to the choice of surgeon. The planned trajectory for the portal placement, determined during the robotic planning phase, is now used to guide the placement of the retractors. Robot arm is sent to the trajectory of the cage or portal, and guide wire is landed on the inferior facet. You can drill a monocortical small hole in facet to keep the guide wire fixed. Serial dilators, in increasing size, are carefully passed over the guide wire. The retractors are then slid over the dilators and locked into position, creating the surgical corridor. The retractors are then opened to provide the necessary exposure. Now, the dissection begins. Remaining soft tissues over the inferior articular process and facet joint are removed. The pars is exposed, along with the lamina, extending medially to the spinous process. The inferior articular process is removed with osteotomy or burr, and the superior articular process over the disc is cut with osteotome. The flavum is removed, and the traversing route is visualized medial to facet joint. The disc is then accessed and cut with a sharp knife. The disc space is meticulously prepared using curettes, disc punches, or disc shavers, depending on the surgeon's preference. After adequate disc preparation and decompression of the affected levels, the cage is inserted under navigation guidance. The cage's position is displayed live on the robot's screen, providing excellent visual feedback to the surgeon. This precise navigation allows for accurate cage placement without the need for traditional fluoroscopy, minimizing radiation exposure. With the cage securely in place, the remaining screws are inserted, followed by the placement of the rod, providing final stabilization. Finally, the wound is closed using standard surgical techniques, completing the robotic-assisted TLIF procedure. This robotic-assisted approach to TLIF surgery offers numerous potential benefits, including increased precision in implant placement, smaller incisions, reduced soft tissue trauma, and potentially faster recovery times for patients. Thank you for watching this video. To learn more about robotic spine surgery, please visit our YouTube channel and subscribe for the latest content. You can also visit our website for more in-depth tutorials. If you learned something new today, please like, share, and subscribe. We'll see you in the next video.